finally, we don't believe in compassion. We think it's not that really important. We've got books, etc. I was just walked past a whole lot of medical students sitting at a table studying this morning, and there's so much of us, so much that we have to learn intellectually that we actually just bypass some of the emotive aspects of medicine, and we don't learn about compassion. So next slide. I think we're over to Tom. Tom, this is you.
This is me. Yeah, thank you, Dr. Bremner. So this is a logistical hoo-ha, and I'm talking just so you guys in Phoenix know I'm speaking directly to our folks in Omaha to just give you a heads up what we're doing, which is, of course, a hybrid between Phoenix and Omaha. In Phoenix, who just spoke was Dr. Ross Bremner. He's a thoracic surgeon at St. Joe's, and he's executive director of the Norton Thoracic Institute. And he and Dr. Nicole Piemonte, who will come in after us as part of the team where we're putting this compassion grand rounds together for you, have been working together for about 2 years, maybe a little longer than that on this. And we have some things developed. So we wanted to do a grand rounds to just give you kind of a heads up on what this is all about. And maybe this is really talk about compassion 101. This is maybe if something came before 101, that's kind of what we're talking about today. So I'm going to spend the next 15 to 20 minutes talking to you about compassion science. By the way, my name is Tom Lenz. I've been at Creighton for 25 years, and I'm in the family medicine department. And I teach a course now to M1s and M2s called Compassion Science. It's a selective. We have an M3 piece in our family medicine clerkship on compassionate care, and then an M4 non-clinical course on relational care, which is the next step on that. And so what I'm going to talk with you about today really is the science of compassion. I think it's a good place for us to start and get an idea about what this material looks like. So I thought I'd start with a conclusion. What seems to make sense from looking at all the data, and by the way, there is a lot of data to relate compassion to patient outcomes, is that the scientific data and our lived experience, at least it tells me that there's something very fundamental about connection and the connectedness and relationship of all things. But here we're talking about people to people, and that compassion seems to be a very tangible and measurable example for that. And so really what I think is a good intro into this is to talk about connection and connected science. And there's a whole bunch of examples we could do. We're going to start with natural science and move to social science. And so we're going to start with really some easy examples from connection science literature. Okay, so we talk about water and the nature of water. And if we didn't have this in environmental science piece, I might stand over here so I can look at the slides a little better. If we didn't have this, this cycle, we wouldn't have, of course, the importance of water. We have the food chain, which of course we know is connected in many ways, and this gives us a great perspective on what connection feels like and looks like from our food source. Of course, we're very familiar with this image of a cell structure, but looking specifically at chromosomes. And if you want to focus at the end of the chromosomes, we know we have telomeres at the end of those chromosomes that sort of hold it together, but those telomeres can grow and they can shrink based on our life experiences, based on some of our behaviors, such as if we don't eat well, if we gain weight and develop conditions like obesity or diabetes, if we're stressed, chronically stressed. We know that people are in a chronically stressed environment shorten those telomeres, and those lived experiences actually shorten lifespan and allow those chromosomes to fray, as you probably heard the analogy, like your shoelaces, like the plastic tips at the end of the shoelaces, they come off and the shoelace frays and leads to premature cell death. There's a connection story there, and that's where I'm bringing us in. One of my favorite examples about this is chemical structure on covalent bonds. And of course, we know from back in chemistry class that there's a electrostatic connection in the electrons from hydrogens to oxygens. There's something recognizable between hydrogen and oxygen that allows them to come together. And interestingly, when they come together, they are more stable than what they were apart. If we move from natural science examples to social science examples, what you're looking at here is work from two researchers at Yale, Christakis and Fowler. They wrote a book that was published in the late I think it was 2018, 2019. Sorry. And what they studied was social networks. And this gives us some clues about our connectedness with each other. And when we think about our social networks, we can think about our families, our work group colleagues, maybe some organizations or clubs that we belong to. All of those come together to create our social network. And we interact with the people within those networks, not in just a one-to-one relationship, as if we were going, I'm going to pick on you guys because you're in the front row, like if we were going to do a bucket brigade and you're connected to her and her and her and so on. But what it looks like is a little more matrixy than that, and that we see people who are on the outside of the network who may be only connected to one person. And then we got a bunch of people in the inside of the network that are connected to a lot of people. And every time Christakis and Fowler looked at different examples of social networks, and you can think about your own, your family, the people you're connected to in those different groups, this is the structure that they come up with. But the interesting part about this is it had some sort of consistency across examples, in that the two things that were most important were the connections between the people. And the reason that those parts were important, and this is all seems like logical, making sense, right? But there's something that flows between people. You're sitting in the front row, so I get to pick on you. But there's something that happens between people within a network. And that something that flows between people affects how people behave and how they think. And then the whole network in itself takes on a life of its own and has its own influence on the members within the network, and the members influence the network itself. Okay, so there's a story about how we interact with each other, a very important connection story in this. But interestingly, if you've ever played this game of 6 Degrees of Separation from Kevin Bacon, right? So you know, the guy in Footloose, I always have to explain this because I feel like I'm, you know, but there is science, and this is actually, we could spend a whole hour talking about this because it's so cool, that there's science to show that everyone on the planet is connected on an average of 6 degrees of separation. So let's just count this out for the people who are sitting in the front row. So from me to you is 1, 2, 3, 4, 5, 6. So for just us that are standing here, everyone on the planet, and this was done pre-social media, so it may be even less than this, is connected on average by 6 degrees of separation. But what's even more interesting is that there's a statistically significant influence out to 3 degrees of separation. So 1, 2, 3. So just the 4 of us standing here, I have a statistically significant influence on you, and you could live on Mars and it wouldn't matter. And I wouldn't even know you, and it didn't matter. Let me show you what the data looks like here. So that every time Christakis and Fowler looked at different examples of how people influence each other, that flow that passes back and forth between people, they showed consistency in attitudes, feelings, and behaviors. So things like political views, weight gain, happiness, and creativity. And I would argue compassion. They didn't study this back then, but I would say compassion would be the same, that there's a statistically significant influence from one person to the next. So what's the data look like? For something like weight gain, there's a 45% influence. So let's just, as an example, say my wife, Nancy, she has a 45% influence on my body weight, as do I on hers. Okay, so she works with a gal named Jeanette, and she sees Jeanette all the time at work. So I have a 25% influence on Jeanette's body weight, as does she on mine. Now I know Jeanette, but I don't see her very often, but I know her. But Jeanette has a brother, Joe, who lives in Chicago. I don't know Joe, but I know they're close and they talk all the time. I have a 10% influence on Joe's body weight. I don't even know this guy. And he's got a 10% influence on mine. Standing underneath that speaker, I think. Same thing goes for happiness, 5, 10, and 6%. And if you don't think 6% bump in happiness is significant, if I gave each of you $10,000 as a separate study, it would increase your happiness by 2%. And so 6% happiness actually is statistically significant. So this tells us a story about how we're connected, and there's a relationship and a flow that goes back and forth. And it tells us something about compassion that I think we're going to get to in a minute. There's another study, if you haven't heard about this, is maybe it's one of the longest running studies in the US. It's definitely the longest running study on happiness in the US. A Harvard study of adult development started in 1938. It's still going. The original descendants, if they're still around, are still being measured quantitative and qualitatively, and now their descendants are as well. The original research question that they wanted to know was what makes for a good life. And so over the course of study period on the original people and then everyone who has come after them, they've collected qualitative and quantitative data. So you can imagine the database of what this thing looks like. And actually the researchers just published, the current directors of this study just published a book in 2023 on this. But when they looked at all of the data across 80 plus years and factored in how much people, money they made, what kind of education they had, where they lived, what their personal habits were as far as eating and exercise, they came down to one single factor that made the most difference on people's lives, and that was good relationship. The quote from their book that they published in 2023, The Good Life, is, "The science tells us cultivating warm relationships of all kinds over and over again throughout is the single most important factor for health and happiness." I think this is something tells us that there's something more that we should be paying attention to about relationships. Getting to the data specifically about compassion, thinking about what we know now, at least get an introduction about this connection science, how that might flow into our data about compassion. We can look at this in a couple of different ways, the psychological data, the physiological data. So I kind of cherry picked a few studies to show you. If you're not familiar with this book, Teresiak and Mazzarelli are two academic physicians who published this book in 2019, and really was just a massive lit review on what compassion does for outcomes. And they looked at patient outcomes, they looked at provider outcomes, which I'll show you some of those too. They looked at health system outcomes, and they brought it all together in one space. And so I'm going to just highlight, and I wanted to expose you to this book too, in case you're interested. But here's a meta-analysis. I'm going to move over to the podium so I can read this a little better. Just as highlighting this from 21 different studies, nearly 1,300 people, that, and I don't expect you to be able to read this, but just highlighting that compassion, when we're compassionate in a healthcare setting, and this, remember, is psychological outcomes, it lowers incidence of depression, anxiety, and psychological distress, and increases well-being. I'm going to move through these rather quickly. For depression, a University of Penn study looked at 185 people and showed a statistically significant difference in high therapist compassion and recovery from depression. Duke study found that compassion reduces feelings of hopelessness. And a separate study looked at the rise in self-efficacy. So if you remember your studies on behavior change, and what self-efficacy means is that the patient that you're talking to actually believes that what you ask them to do, that it's going to make a difference, and they believe that they can actually do that. That's what self-efficacy means. And so when we look at this data, and there's a lot of it related to compassion and whether people take their medications or not, a little trivia for you. We always used to joke about this in pharmacy, that the worst drug problem in America is that people just don't take their prescription drugs the way they're supposed to. A little trivia for you: only half of the people in America who have a chronic condition actually take their medications the way you all are going to prescribe them or do prescribe them. So it's a massive issue. And we know from studies, and we have a lot of them related to compassion, that when a physician shows a patient compassion, that they actually take their medications more often than if they do not. And this study shows that there's a University of Colorado study that explicitly looked at that and showed that adherence to antidepressant therapy increased, and actually even whether they went to the pharmacy to get it filled or not. Sometimes we think about this compassion as in, did it make a difference right now? But we have several studies to show that it has persistence, and this shows us that people who experienced depression that persisted out to 6 months. If we switch gears to anxiety, looking at a study from Hopkins that were mostly breast cancer survivors that were highly anxious, that it has statistically significant less anxiety following the visit. A UCSF study interestingly designed to show a cumulative effect that every compassionate statement you make reduces a person's anxiety by 4.2%, but if you say 2 compassion statements, then you double that to 8.4%, and so on. Switch gears to the physiological benefits to this. This was actually studied for the, at least what we know, for the first time in the early 60s, looking at analgesia from an anesthesiologist perspective. And they interestingly designed a study where the anesthesiologist wanted to see if, and this is what Ross just commented on, do you have good technical skills? Would you rather have good technical skills or high compassion if you're hiring a physician to do your cabbage surgery, if I can say it that way? This study actually wanted to measure that to see if an anesthesiologist could have the person skills to make a difference in addition to their technical skills. And their new experimental therapy was simply having the anesthesiologist go visit the patient the day before and say, hey, I'm Dr. So-and-so. I'm going to be working with your case tomorrow. This is what we're going to do. Do you have any questions? I'm going to shake your hand. I'm just going to spend a little time getting to know you and building rapport, as they said. This is in the 1960s. And so they published 2 studies related to that same design, one in JAMA in 1963. They showed that the special care group more than doubled the effects towards achieving the prospectively defined adequate sedation versus pentobarbital. The other study looked at post-op surgery, and that the special care group, again, all they did was go say hi to them and introduce themselves. Their special care group required 50% less opiate pain medication post-surgery, and actually statistically significant out of the hospital sooner. Nursing studies show the same things. There's tons of those. What about diabetes? So when you measure a physician's compassion and you can scale it low, medium, high, what this study showed was that 29 different family physicians, 891 patients, that when those physicians score high on the empathy, they use the Jefferson empathy scale. There's different ones for this. Their patients' odds for optimal blood sugar control was 80% higher than other groups with lower compassion. 80% also higher odds of blood glucose control. Different study, but still looking at patients with diabetes. 242 physicians, nearly 21,000 patients. They found that physicians who scored high on compassion scales their patients had a 41% lower odds of serious diabetes complications. The data is super overwhelming. I just scratching the surface for you. So what is this? We know that now that this benefits patients. What does this mean for you? This is a really interesting part, and this gets back to, this is why I show this thing with Christakis and Fowler. I'm going to pick on you again because you're in the front row, but there's a flow. If we work together, there's a flow. If you're my patient or if I'm your patient, there's a flow that goes back and forth here. If I offer you compassion and you receive it, and then you offer me compassion back and I receive it, there's something that I experience that is beyond what we generally would consider is part of our therapies for care. Okay, so this has an effect, a direct effect on providers. And what the reason that I wanted to show this is partly because the incidence of burnout we know is really high. Okay, so start tracking this closely in 2011, but the latest data up to 2023. And if we put a line on this, I didn't show this, I have a different graph for this, but in general, physicians in America experience burnout. About half of physicians in America, about 50% experience burnout at any one time. Okay, so in general, if you take all of the physicians across the US, half are experiencing burnout. So we've been tracking this for quite a while, and it's a really important topic all by itself. And our Surgeon General is paying really close attention to this and trying to move initiatives forward. I wanted to bring light to it relative to compassion because we have studies. I'm only showing one here. I could have shown several more, even prospectively designed studies that show there's an inverse relationship between compassion and burnout. And what that means is that those physicians who have higher compassion experience less burnout. Those who have lower compassion experience more burnout. This is consistent across several studies. And why is this? I think we have some neuroscience to show that we do, because this connectedness, this goes back to connection science stuff, this connectedness has an autonomic nervous system connection, and that the parasympathetic nervous system kicks in, as does oxytocin, and we feel a connection there. And that has a physiological effect that we know makes sense for our own health and well-being. But we also know just from other social science studies that when we feel like we're doing something for someone else, that we have a health benefit related to that. So compassion is being called an antidote to burnout now because of all of the literature, and that the traditional philosophy that says, don't get too close to your patients because they will lead you to exhaustion and burnout, the science doesn't support that. The science, in fact, shows the opposite of that. And I want to be careful here to note that this doesn't say that you should be working 24 hours a day and just engaging with people. And as long as you're engaging with people, your health is going to be good. That's not the case. You still need a balance in life. But that when you are working, that engaging with your work and engaging with the people you're working with matters for your health as a provider. And the data is really clear to show that. And it tells us something about connection and relationship as being fundamental to life. So we have several barriers. Before I hand this back over to Ross, we have several barriers to compassionate care, and the data is really clear about this. 60 to 90% of compassion opportunities are missed by physicians. And why is that? Most say, and I'll show you this in a second, that most of the time I just don't have time. I don't have time. I'm going to show you time studies in a little bit after I hand it off to Ross. So I'll come back and show you what this data shows us about time. Do we have time or don't we have time? But there are a lot of structural barriers, including electronic medical records, which Ross had already talked about. The cultural and personnel barriers are also in there too. So 56% of physicians believe they do not have enough time to show compassion for patients. And there's also when you look at how we perceive time, when the status of our positions is higher, we feel like we don't have enough time anyway. So there's a connection there too. This is where I hand it back over to Ross. He's going to talk specifically about time, and then I'm going to come back with some time studies. So Ross, it's all yours again.
Okay. So I'm going to just tell just a little bit about time. Obviously you can have a whole series of lectures on this and our perceptions of time, but essentially we always feel rushed, right? We've all got time poverty. None of us have enough time. But there's a very good study that was done back in 1973, which I've used in my lectures, and just so happened that Tom and Nicole have used in their lectures too. This was a psychological study done by Darley and Batson at the Princeton Theological Seminary. And actually, the article is called From Jerusalem to Jericho, and I implore you to chase it up and read the whole article, because they actually there were lots of different things that they studied in this experiment. But one of the things that we want to talk about is the time part of it. So they actually were given a lecture on the Good Samaritan, and then they took the students in this theological seminary, and they divided them into two, and they asked them to go across to another building on campus and give a lecture. And they'd actually asked them to do two different lectures, one on the Good Samaritan and one on job opportunities on the campus, because they wanted to study whether or not they were thinking about the Good Samaritan, or whether they were thinking about something unrelated, whether that would affect their response to the next piece that they did. And then they also divided them up into those. They said, we really need you to rush over and give this lecture. Okay, we're late. I forgot about the time. Please rush over. And then the second group, they said, you got plenty of time. Make your way over to the next, get a coffee on the way, and give your lecture. And then what they did is they positioned an ailing person on the sidewalk in the path of where they were going. And so they wanted to see whether or not, those in a rush would stop, or those that had plenty of time would stop to help this person after having a lecture on the Good Samaritan, right? You all know the lecture of the Good Samaritan, who's the only person who stopped after everybody passed by this poor bleeding person on the side. So next slide. So next slide. And it's quite amazing, actually. So those in a hurry, only 10% of them, 1 in 10, actually stopped to help this person on the sidewalk. And if they were unrushed, I mean, this is also a number that surprised me, only 63%, but a huge difference between those that were not in a hurry, those that were in a hurry. And they broke down the whole other things that are very exciting to look at in the paper if you take a look at it. But I think that this speaks a lot to the lives that we lead in medicine, because we all feel rushed, right? We feel rushed, and there's so much that we have to get done in such a short period of time. And people are looking to us to meet their needs as well. Our patients got to make rounds, our students, etc. And so there's a pull on us, and this actually impacts our ability to actually offer compassion. And I would offer to you, and Tom's going to show you in a few seconds, that it's actually not the fact that we don't have time to give compassion, because compassion really doesn't take much time. And I would actually say that it would save you time. So next slide. And next slide. So we all think it takes a lot of time. And Tom's actually already shown you a slide that said 56% of us say that we don't have time to be compassionate. In fact, there was one study that showed just the power of 40 seconds. Next slide. This was an oncology clinic at the great and powerful Johns Hopkins University. And they asked the oncologist to actually say the following statement to the patients that they had with cancer, right? This is an intense interaction between patient and physician. I know this is a tough experience, but I want you to know that I am here with you. Some of the things I say to you may be difficult to understand, so I want you to stop me if something I say is confusing or doesn't make sense. We're here together. We are going to go through this together. I will be with you each step of the way. And what they found, next slide, that these patients that actually had that statement said to them actually reported less anxiety. They had more trust in both their physician and the medications that they're going to have, more hope to their outcome. They felt much more accepting of the proposed future treatment. 40 seconds. Next slide. So there's actually an entire book devoted to this on the antidote to suffering. And Dempsey actually studied the time aspects of this. And over 30 years, she said that she believes that it takes an average of less than a minute to actually connect passionately with your patients. So you can work out what 1 minute is as a percentage of your day, right? 20 minutes is 1.3% of your day. So next slide. So then, and this is actually a question that Tom actually asked me, does it need to even take 56 seconds or 40 seconds? Isn't this something that you should be able to carry with you in your presence, in your daily lives as physicians? Next slide. So I'm going to hand over to Tom.
So I think this is back to me. What I wanted to show you, and Ross just touched on the time studies. There's a series of time studies that look specifically at this, about offering and how much time it actually takes. And so this first study is the one that he already highlighted. I wanted to add it back for completeness here, but it was a Hopkins study. Again, what they showed in 40 extra seconds of time of treating a patient who was an oncology patient with a cancer diagnosis, is that they reduced the anxiety to a significant level at the end of the consultation. What I think is important to understand is the language and the consistency in the language that they used it was about we, and it was about together, and I'm not going to leave you alone. That is the consistency on all the time studies. Here's another one that they did in the Netherlands, they used analog patients here. So they were patients who were in the shoes of patients receiving bad news. It's a valid research design, but these folks didn't actually have a diagnosis. But what I wanted to show you here, their intervention took 38 seconds and their language was very similar. Whatever we do and however it develops, we will continue to take good care of you. Notice the we's. We will be with you all the way. We're not going to abandon you. You are not facing this alone. That's compassion language. There's a lot of ways to talk about what compassion is, and it goes beyond what we're doing in this grand rounds. But just to give you a sense of what this looks like, this is about connecting with people. And in another study, you could make the argument to say, okay, so well, what about all these people who ask me question after question? This study addressed that, and they looked at compassion sequences. And that was where, did you have an opportunity to say something compassionate to a patient because they asked you a question? So they measured how many questions, how many sequences. And what they showed was that on average, it took 31.5 seconds for the patient to ask the question and for the provider to provide a compassionate response. The average number of sequences per patient was 2.5. So in this study, it was about almost 80 seconds of extra time to address that patient's needs. When you look at all the time studies together, and this is where the power of 40 seconds comes from, the median time is 40 seconds. And just looking at how they list out and reminding ourselves of the Good Samaritan experiment, that you have these people who are studying to be seminarians, and they themselves thinking about the Good Samaritan to give a lecture on it, but were made to feel like they had not enough time. They themselves passed on by. I mean, it was the same setup and they just went on by. Imagine what the debrief felt like for that. Imagine what that reflection felt like for those folks, the moral injury that they were feeling at the end of that one. But I think this tells us something about healthcare and how we all feel rushed. And I would argue that I think there's a way to bring this 40 seconds down to 0 if our way of being is just simply compassion. If we are putting ourselves in a position to have this relational exchange with a patient, I think it costs 0 seconds of time. I square up my shoulders, I look you in the eye, I get down on your level, I might shake your hand, I might touch you on the shoulder, I might do something that says, I'm with you on this journey. That is part of your regular language. That's compassion. And I think if you work it into your regular way of doing business with a patient, it takes 0 extra time. So back to the conclusion that I started with, this is really a story about connection and relationship. And I think that fundamentalness of life tells us why compassion, the data is so compelling for compassion. Okay, so I get to turn it over to Nicole. Now, Nicole, do you just want to introduce yourself to everyone here in Omaha too?
Absolutely. Can you hear me?
Yep.
Yes. Okay. I'm Nicole Piemonte, and been at Creighton now for 8 years and do a lot of work on thinking about vulnerability in medicine and how tapping into our own vulnerability can help us connect to others. Really compelled by the science that my 2 colleagues have showed you. And I know that intuitively, you already know that compassion is good and that your compassion is probably what compelled you toward healthcare in the first place. It's my belief that the difficulties we have with vulnerability and tapping into our own pain can trip us up and prevent us from engaging compassionately. So then we can say, I don't have time. There are too many things to do. The electronic medical record is preventing me from doing this. When really we've got a lot of fear of tapping into our own vulnerability so that we can feel the pain of someone else in front of us. So that's why I think engaging in self-compassion is so important. Next slide. There's kind of a running joke that I always am quoting Brene Brown in every single thing that I do, but I cannot help it. So what she says is one of the greatest barriers to connection is the cultural importance we place on going it alone. Somehow we've come to equate success with not needing anyone. Many of us are willing to extend a helping hand, but we're very reluctant to reach out for help when we need it ourselves. Next slide. It's as if we've divided the world into those who offer help, those of you in healthcare, and those who need help, which we usually perceive as patients. And she says the truth is that we are both. Medicine and medical education is like the epitome of reinforcing ideas of going at it alone and not acknowledging our own vulnerability. And when we do that, we disrupt the opportunities for connection that Tom has just explained. Next slide, please. So in medicine, we know that disengaged care has become normalized. It feels abnormal to engage in the connection that Tom and Ross have talked about. They're swimming upstream just to connect because the normal approach has been disengagement. Next point, please. So professional distance is seen as a virtue. I see this among first-year medical students. Oh, I know that I cannot connect too much with my patients because I'll burn out. I can't feel too much. I have to learn how to cultivate a professional distance. But when we do this, we prevent opportunities for compassion, because compassion requires co-feeling or feeling alongside someone, which requires that we tap into some of our own pain. Next slide, please. This just came out in JAMA, Piece of My Mind. And this was last month that this came out, and my colleague, Dr. David Weisinger, shared it with me. And I think it's a really important reminder. So the author says to us on the next slide, she says, as a medical student, the not so hidden curriculum taught us that doctors were strong physically and mentally, even at the expense of their own needs. Some of you all are really good at some radical self-neglect, and that gets reinforced. Next slide. But we know that you're affected by your engagement with patients, even at a cellular level. Thank you, Tom, for showing us that. At a cellular level, you are affected by your engagement with patients. Next slide, please. So we know that your responses, your feelings, your reactions matter. So yes, patients matter, but so do you. Next slide, please. So we're really focused on patient-centered care. And you can click through this, Tom. But what I want us to focus on is relationship-centered care. And we just heard that relationships matter because the practice of medicine is interpersonal. This was really popular in the 90s, and several of the talks I give refer to relationship-centered care because I'm kind of committed to rebirthing this idea. It's a retro from the 90s, but what happened in the 90s is cool now, right? So we're bringing back relationship-centered care. And you can go ahead and click through that, Tom, but there are principles of relationship-centered care. Personhood matters. Affect and emotion are important. We don't say that much in medicine, but affect and emotion are important, and that relationships are healing. And you saw that in the studies just a few minutes ago. They're actually physiologically healing, and that means for you too. Next slide, please. So how can we do this? It is a lot of reflective work. And all of you right now in this room, this is related to what Ross had you write down earlier. Your authentic why. Why medicine? Why healthcare? Why do you have those descriptors of what a good doctor is or a good clinician? And tapping into that. You can click through this, Tom. So what does it mean to be successful? Is it to care well for somebody? That's probably why you went to medical school. Or is it to achieve a particular outcome? Or to meet a metric? What does success really mean to you? We have to admit that the reality is you are asked to meet metrics. That's the reality. And it's leading to disconnection. Both of those things can be true. So what do we do with that? How are you effective and productive, but also embodying connection and compassion? Next slide, please. I want to end with this quote. This is from the same article I alluded to. She asks, what if my training had encouraged exploring the emotions of our patients and ourselves? And what if we learned that martyrdom has no place in medicine, and we can and should stop modeling this for trainees? What we could model instead is how we are affected, how clinicians are affected all the time, both in beautiful ways and painful ways, and model this for our students. You know, we have just a few minutes left. I'm going to hand the audio over to you, Tom. They'll probably have more questions for you. And if people have questions, either put it in the chat or just shout it out, and I'm going to hand this over.
Hey, any questions?
We're going to turn the mic off and we'll do the in-room mic.
Okay.
So everybody can hear. Okay.
I'm good to talk.
Yep, you're good.
So questions on the data, there's a little bit of philosophy on this too, right? We're trying to make this connection between relationality, as I like to say it, this relational exchange that seems to be so fundamentally important to life at all levels, and what that means for patient care, moving beyond being a great technical expert at your job to being this someone who connects to combine those two together. That's the point of what we're looking at today. It's okay if you don't have questions. So yeah, Brother Emmett.
I would still think that it's the time element, even with the 40 seconds and everything. It's the time element. I mean, most of our learners are compassionate people. They've demonstrated that long before they got here, and they reinforce that here. But it's still, certainly in primary care, it's the time element. There are so many things to do. That really, even if you try to be compassionate, still, it's that time element that I think sticks out.
It's hard to get past the time element. So the question, if you didn't hear it in Phoenix, is about the time piece. And that's why we spend so much time on the time part, and that there's studies actually related to it. And that part of it is a very real part of the job. But also part of it is a perception. We know that the part of it is a perception piece. If you didn't change anything in what you do relative to like, okay, I'm going to, and hopefully you wouldn't say a script like what that was up here, that it would be authentic about the we and together and not abandoning you type of language. Could you work that into how you normally do talk to patients, interact with patients in a way that costs you zero extra time? This is kind of a reflection, rhetorical question. What is that possible for you to do? Or do you need more time, in order to do this kind of thing? And even still, and I didn't add this up here because it's beyond our conversation today, but there's a lot of science to say that there is an energy that comes from you, all living things, amid a low frequency electromagnetic energy, including you and me and your dog and trees that are around you. And that energy has a frequency, and if you're stressed, that frequency, it's really cool to map it, super jagged. But if you're kind of like this, and this gets into woo-woo, some of my students just tune me out when I do it. But your energy flow, and when you map it, it smooths out. And if you walked into a room before and you're like, wow, this room's heavy, I can feel something going on, there's some tension going on in here, you're feeling that energy, and you're also contributing to it in some way. So we know this thing is real, and there's a lot of solid science to support that happens. If you have an energy that you're bringing to your patients that they can feel, okay, as opposed to, I'm always in a hurry, I'm always rushed, I never have time to answer your question fully, they're going to feel it in ways beyond what they hear through their ears. And we know we've got science to support that. If you can bring an energy that moves beyond the time issue too. So there's something about connectedness and the connection science about your low frequency electromagnetic energy that you bring to the room. There's something there too.
Can I make a comment, please? Hello.
Yeah, go ahead.
Hi, I'm one of the medoncs at Valleywise in Phoenix. So, I mean, I've noticed this in my own behavior, like I'll come in with like all this good energy in the morning and it's really sad. Like I want to be better, but it's very difficult. And I'll be like, I'm going to be so nice to everybody. I'll answer every question. And then 2, 3 hours into the day, like you're just so emotionally exhausted that when you're being asked the same question for the 100th time, like you're just not able to bring too much compassion in it. So I think part of it is being human also, and it's really hard. It's like a continuous process.
That's a great question and comment, and I don't want at all to any of this information to say, hey, if you're just more compassionate, your life's gonna be fantastic. I mean, everything's great. You know? That there is a reality to all of this. That there is an emotional exhaustion. This is part of one of the 3 criteria that define us as being burned out as the definition. Emotional exhaustion is one of those. Physical exhaustion is another thing too. It's not part of burnout. And how do we care for ourselves as part of Nicole's piece? How do we care for ourselves in a way that we can still maintain this something we want to be for our people and for our college and for our organization? And so that comes back to all the other things that, your mom said was good for you, like getting enough sleep and eating right and exercising and those types of things too. That's all part of the larger picture of this too. So this isn't the end all be all, but this is a conversation when we talk about this related to provider burnout about self-care and taking self-care seriously. And that course that I teach to the M4s called relational care. The subtitle of it is taking self-care seriously. And so this brings all of this together in a reality. Okay, we have this institution that we have to work with, this thing that imposes demands on us. But is there a way to manage all of this together? And I think the moral of the story is the old way of disengaging to save myself from all of this. The data says something different.